So my name is Dr. Primus Ochieng. I'm from Nairobi, Kenya, and my background is in clinical oncology. And I trained as a clinical oncologist in South Africa. I graduated in 2018. And for a period of like 10 to 15 years, we only managed to train 4 oncologists. And that time, in a population of 50 million, there were only 8 oncologists who were been trained and certified to take care of the patient. And so the demand for services was very high because there were a number of patients who were developing cancer were growing very fast. So after training, I went back to Kenya, and I'd actually thought of going back to South Africa and work there. So the government challenged me that we actually need to train more, but they didn't have money to train because it's too expensive to train one doctor. It took 4 years, very expensive. And the other thing was that the training in South Africa was based on the South Africa health needs or the oncology needs. So we needed to have actually come back home and start training so that we could train to suit our needs. And so I was tasked with the responsibility to set up a training of oncologists, which after having gone to Christian Oncology in Britain for 1 month under IEA program, then I came back and started the program. There were 2 of us, but 1 of us left the country, so I was left alone. So as per now, we have actually trained 8 oncologists who are currently working in the country and have 30 oncologists under my training program. And it's the only training program in Kenya. That has been a lot of challenge because we have struggled with one faculty, and we have been helped by American team, Mayo Clinic, giving students some lectures, Stanford University, and I've also been giving a bit of practical online training. But there are a lot of challenges with that because the American oncology training is quite advanced today. And also the pattern of their cancers is quite different. For example, like head and neck, the Americans don't see nasopharyngeal cancers. They don't see a lot of cervical cancers. Now, most of our patients actually come to India, and therefore India would be a more appropriate partner in terms of we work and help us to train. Now, I've had a lot of experience with India as a country. In 2020, I was part of a task force who came down here and spent 1 month with a team from Kenyatta University Teaching Referral Hospital, a team from the ministry, and a team from the other stakeholders. We spent 1 month here in India, and we went around and then came up with a blueprint. And one of the areas that when I was here, I came to learn was that, and that was actually being shown by most patients would want to come and get treatment in India, that the treatment here is quite advanced. The treatment here is a little different from a treatment in that the way the doctors here are trained to take care of the patients is a little different from the way we train our doctors in our country in Kenya. It's a lot more of empathy. There's a lot more of got so much involved in the day-to-day treatment of the patients. The doctors are quite want to see patient outcome, and therefore they want to follow up the patient very well. Another thing is that there are a lot of practical way doctors here approach patients. It's a little different from the American approach because America, they have all the facilities, they have all the PET, they have MRI, and healthcare is actually well funded, and this makes it very different from a third world country like Kenya, where healthcare is not as funded as in America. So as a university, we have been looking for partners that we could actually work closely with, and I think this would be a good opportunity for me, and I think Apollo could come very fast on the front line so that we could work together on how they could bridge in and help us to train the doctors. Most of my students have been telling me they would actually want to come to India and see the way actually India patients are treated. Last year, actually spent my own money and I was at Medanta for 6 months at New Delhi and actually came there to learn on how to do stereotactic. But when we started, we realized that my skills weren't very good in VMAT, so I spent the 3 months mostly learning VMAT and a little on stereo and a little on the cyberknife. But when I interacted with the DNB students, I found that training approach was quite different from my training approach that we train our students. They were actually quite practical based, hands-on, and they were with the patients. And the students were as students, quite a little different from us. And I felt that we need to pick up that approach. And I shared that with most of my students, and they're actually willing to come and then pick some of these soft skills, pick some of these practical skills which could help us. In terms of referral, I've actually referred to a number of patients here, like about a month ago. Last month, actually, I referred a patient, a young man who is only 34 years old and had a small esophageal cancer. And I told him that from my own experience is that we don't treat so many patients with esophageal cancer and manage to cure them because our surgeons are not seeing so many. And for you to cure esophageal cancer, you need to have done a lot of so many of these patients. And so we got in touch with the Apollo team in Nairobi, and they were very fast. And actually this patient told me he's currently in Chennai Apollo, and they did surgery and it's recovering, and this was fantastic to me. So one of the things I feel that we need to do is that Apollo has established both infrastructure, human resource, and as systems which can actually help many of our patients, help many of our doctors grow and learn. And this is something the university where I train other students, we could collaborate and get a way of which students can come. I was thinking we could actually involve International Atomic Agency, IEM, the big pharma companies like AstraZeneca, Roche, and we could come up with sort of like a grant system in which students can be brought here and they can be attached to various centers for say 1 or 2 weeks before they graduate, so that they actually pick certain skills, because no doubt India has very good soft skills. Now, in terms of setting up a center in Kenya, one of the big problems our patients have is perception. And however much we train our oncologists even to the level of India, many patients believe that when they come to India, they get better and they get better treatment. And this is something which we really have to take into account. So they not only just come for treatment here, but they also feel that if they come through India, their cancer will be sort of like cured, or if it is metastatic, they will be able to live long. And this is the perception of the people. And every patient, if they could afford, they would come here. I've seen so many patients who've late coming just for consultation. I know 3-4 months ago, I sent 2 patients again. They just came, and the fact that they came, they were stage 4 disease, the fact that they came to India and they were consulted and they were given drugs from India and they came back and we are administering this drug. This was a big plus to the family. They felt that they have done something very great to them. So as we go on training, I think this is something which I think we should also develop, that we could have an easier way of patients just come, they could a package which can allow them to take 1 or 2 days, feel that they have been given a second opinion here, they have actually been touched by the doctors here, and then they can go back to Kenya, and then they can actually go with the medication and administer them. And that's where we'll have a satellite clinic in the country, but then the medical tourism will have to continue for quite a long. Now, the other thing many of our patients believe is that the drugs which they get when they come here from India and the drugs we give them in Kenya are different. And so they would prefer to come and buy the drugs here and go back with them home and we administer, because of course they can't stay there long. Yeah. In terms of radiation, we know we are, of course, and thanks to Apollo, they have actually helped Kenyatta University Teaching Referral Hospital start or jumpstart their cyber knife. Of course, it's still a learning curve. They're growing and they're doing, and that's a good job going on. So patients won't mind coming here. They'll be discussed by the Indian doctor physically, and then they're actually told, you have cyber knife, we can help you need cyber knife treatment, you can help the Kenyan doctors to do that, and they can go and get the treatment. The same with VMAT, because now we have like 4-5 centers with the VMAT treatment. So that's some of the things I think we need to do, but we need to enhance the second opinion where physically patient come up. Now, skill transfer is very important. We are still growing in the area of surgical oncology, the area of hematology, the area of transplant, and we feel that Apollo need to help us grow in those areas. And then these are areas which are very good, but we also need Apollo probably to get, if they could have like a clinic, but also if they could avail their drugs or they could help source drug. We have, our boards don't control the entry of drugs very well. And so we have, take for example like doxorubicin, which is a chemotherapy drug. We have like 1,000 of different drugs. And what patients believe that the drugs that land in our market, probably some go through the wrong route or the wrong way, and so they probably are not the right drug. But when they come to Apollo and Apollo dispense chemotherapy for them and they go back with them, that chemotherapy to them works. Probably as a perception, but again, sometimes you cannot just ignore the perception of the people, because that's what the people want and that's what makes them psychologically get well. So to me, this collaboration, we need to move it from where currently it is and moving to a step higher, and then involve other stakeholders in terms of funding it, and we regularize it through the university, through the ministry, and then through the other institution. I know you have been working with the private sector like Safaricom organization. Safaricom actually has a fund which help cancer patients. But if you train 1 or 2 cancer doctors very well, they can help many patients. Most patients from the neighboring countries also seek treatment in Nairobi, and therefore, if we train or if we enhance our infrastructure in Nairobi, if we enhance our human resource in Nairobi, we'll not only be taking care of patients from Kenya, but we'll be taking care of patients from the region. We can also help work with Apollo in terms of like Democratic Republic of Congo, where I've actually done a medical camp 2 years ago, and we've been trying to work closely with the team in Goma. So Goma is the area where the currently war is going on, and they have no cancer treatment, they have no facility. And this is something we can work closely with Apollo, that we can make it easier for team from there. We can set up a clinic, we can always do medical camp with their team, and I can coordinate that from the university. And this would go a long way on helping the vulnerable people, especially people who are at war and cannot access service. So to me, Apollo has a big chance, but let's work with the government, let's work with the universities and with the community, and we can actually make a huge difference and go very far.